The HRCT is required for all patients who have interstitial lung disease where there's a suspicion of IPF. It's typically helpful to get both inspiratory and expiratory images. Expiratory images are helpful to rule out air trapping, which can be seen with chronic hypersensitivity pneumonitis, which is one of the mimickers of IPF. If there's a distinctive radiographic pattern in the appropriate clinical context, it might be enough to make a diagnosis of IPF. So you can have a UIP pattern, or you can have a possible UIP pattern. A possible UIP pattern by itself is not enough to attain a diagnosis, but together with the right clinical presentation, it could be sufficient to attain a clinical diagnosis of IPF. So by way of example, a correct clinical situation or appropriate clinical situation might be a 78-year-old Caucasian male former smoker who doesn't have any other exposures, who has crackles at his bases and has a possible UIP pattern. If you put that constellation of the clinical together with the radiographic, that might be enough to attain a diagnosis of IPF without necessarily going on to a surgical lung biopsy. The HRCT provides greater detail of the lung parenchyma in terms of the cuts, which are typically less than around 2 millimeters, and you can see the definition and enable you to pick up the subpleural reticulation, the honeycomb cyst, the traction bronchiectasis better than a regular CT, which doesn't quite give you that level of definition. A UIP pattern is characterized radiographically on HRCT by basilar predominant subpleural reticulation, the presence of honeycombing, with or without traction bronchiectasis, and the absence of inconsistent features. Inconsistent features might be cysts, ground glass opacification, nodules, consolidation. If you have any of these or too much of these, then that would make the CT inconsistent for a UIP pattern, or perhaps new terminology that's coming out, indeterminate for a UIP pattern. If you lack honeycombing, but you just have subpleural reticulation, that would be regarded as a possible UIP pattern, or more recently, a probable UIP pattern. Honeycombing is a key characteristic of the UIP pattern. These are defined as clustered, thick-walled cystic spaces of similar diameter. Usually you see them stacked up at least in 2 rows. Sometimes 1 row is sufficient to make the diagnosis of honeycombing. Usually it hugs the baseline or the subpleura of the lungs in order to be regarded as honeycombing of IPF. Occasionally it might only be seen in the upper lobes, and certainly the presence of honeycombing in the appropriate clinical context increases the likelihood of a UIP pattern and a diagnosis of IPF.